Good morning, good afternoon, good evening, depending on where you are on the world, on the planet. I know it's very early for Peter. It's end of the afternoon for Natividad. So yeah. Okay. Okay, let's start. If you I will continue to accept all people that want to attend. So this webinar is, of course, registered and will be available on DEBRA International website. Thank you for joining today. Please ask your question in our chat, and the speakers and I will answer at the end of the presentation. Megan, if you want to say also a few words on Wordly software, could be useful for people who are not native in English, like me.
Of course. So for the webinar today, we have Wordly available. I've sent the link in the group chat. So all you need to do is click on it and it will be a live translation into any language. You just have to choose whichever language you would like to read. So hopefully that will be very useful for some of our attendees who may not be completely fluent in English, or even if you just find
Yeah.
it easier to read subtitles as people are talking. If you have any problems accessing Wordly, please just drop me a message on the chat and I'll do everything I can to help you. Thanks.
Thank you. So, thank you. Thank you for joining this DEBRA International webinar. Today we will have the topic of today is an update on new therapies and medical devices for our EB patient and mainly for wound care. And I want to introduce our two speakers that accept to work with us on this presentation. So we'll have a first part on new gene therapy with Dr. Marinkovich. He is director of the Blistering Disease Clinic in Stanford Healthcare and associate professor of dermatology at Stanford University School of Medicine. And he was also primary investigator for gene-free trial for the US FDA approved Vyjuvek. And then we'll have a second part on more focus on new medical devices. And it will be presented by our dear Natividad Romero. She's a nurse at DEBRA Spain since 2008, and she's the coordinator for the association's family support team. And she is an expert for EB patient holistic care, especially in wound care. So thank you both for accepting to present today this webinar of DEBRA International. And I leave the floor to you, Peter. I will change the slide, so please feel free to ask me when you want me to change the slide.
Okay. Well, thank you very much for having me come today. And I am I would like to be able to talk to you about new advances in gene therapy concerning this new drug called Vyjuvek. And I'll tell you a little bit about how we made it and how we developed it. And then also I've been using it for a number of years, and I'd like to just tell you a little bit about how to get the best results because perhaps it may not be on the label, and I really want to see all of you get the best results that you can with it. So with that, can I have the next slide, please? So I don't think I need to really tell you about this disease. You all know it very well, but just suffice it to say that it is a terrible disease that it's our enemy that we want to be able to fix. We want to be able to correct EB, and that's our common goal all together. We're all working together. DEBRA International, all of us researchers, patients, families, we're all in this together, and you know, we all need to be able to make a better life for patients with EB. And So far, all we have is just the standard treatment, but it's very important. So, we try to promote wound care. We want to use non-stick dressings, the silicone-based Mepitel, Mepilex is, of course, really popular. And we like to promote the using ointments to the skin to kind of keep the wounds moist so that the dressings don't stick when you pull the wounds off. And we like to treat infections. We're using more antiseptics now instead of antibiotics to prevent the emergence of the resistant bacteria. Nutrition is so important, to try to help promote the wound healing. You need to have good nutrition. And then when you're anemic, the wound healing is slow as well. And so you want to be able to treat the anemia to promote good wound healing. And of course, we want to be able to find these squamous cell carcinomas and remove them as quickly as possible. And the hope is that as we use gene therapy and keep the wounds under better control, that the incidence of the cancers are going to be less. And I just mentioned before that this treatment is also, it's supportive therapy has been with us for a long time. It's so important. And it's also important when you're using the gene therapy. And I'll talk about that in a moment. Can I have the next slide, please? So this is a little cartoon which kind of talks about the protein that is absent in or not functional in dystrophic EB, and that's collagen 7. And this shows how collagen 7, it's like a little string that then sort of winds around itself and forms a rope. And then the ropes kind of collect together to form big ropes. And that is how the anchoring fibrils are formed in the skin. And the goal is to, with the anchoring fibrils, hold the two layers of the skin together, the epidermis and the dermis. And in collagen and in dystrophic EB, the anchoring fibrils aren't working properly. And we need to be able to put new anchoring fibrils in to make the skin stronger. And it's kind of like you're sewing the skin together. And when you don't have that, then when the skin gets bumped or traumatized, then you're going to get blisters. So the goal is to get the collagen 7 back in. And this is why we're using the gene therapy. The next slide, please. And so this is the gene therapy. And there's a couple of different ways you can do gene therapy. One type is where we do biopsies of the skin. We put the correct gene back in the skin, and then we transfer the cells back to the skin. And then this is something that we're also very active in doing. There's a new drug called Zevascan, which we developed here at Stanford also. And it's cell-based therapy, but it's a lot more involved, that you have to do the biopsies and have to go to the operating room. This therapy that I'm going to talk about today, this is the one that's being approved in Europe, and you all are starting to use it. So I will focus on this therapy, and it's a lot more simple. Instead of having to do biopsies or grow up cells, all you have to do is just put the medicine on the wounds. And the best way to do this is, as you can see on the diagram, you can see that you put little tiny dots, little drops on the skin about 1 centimeter apart. And the drops can be very small. And so it takes a little practice to get them on the skin. And then you want to avoid, touching the wound because it's painful. So you just kind of very lightly dab the syringe on the wound, make the little dots, and then space them out about a centimeter apart. And then you cover it with an occlusive dressing. And we'll talk about the different types of occlusive dressings. We use plastic wrap for the clinical trials, and it works, but it can be occlusive. And there's some other alternatives that you can also use. But the main thing is you want the wound to be clean and not with a lot of drainage and not with a lot of debris over the top. When you have the drainage, then what that does is it dilutes the Vyjuvek. And then when you have the fibrinous debris or the gunk over the top of the wound or the crusts, then that prevents the Vyjuvek from getting in. So you want to have a nice, clean wound. um, and then in that way, you'll be able to get the best results with the Vyjuvek. So really, what you want to do is decide ahead of time what wounds you want to treat with the Vyjuvek, and then start working on those wounds. Do the super good wound care, get the crust off, get all that wound debris off. Treat with antiseptics or good wound care to be able to stop the wounds from draining and get a nice clean wound bed there that's not draining so much, that doesn't have a lot of gunk on it. Work on it for a couple of weeks. And then once you start using the Vyjuvek under those conditions, you're going to get the best results. So let's go to the next slide. And then this just shows the results of the Vyjuvek in the early trial, early phase 1/2 trial. And you can see that the BVEC treated wounds, this is the generic name for Vyjuvek, it's BVEC. And you see that those healed 100%, except for one wound here, this one, P3, W3. But then we re-enrolled the patient later, and then it healed at a later phase of the trial. So all the wounds treated with BVEC healed after 3 months, whereas the placebo wounds did not. So what happens is you get some healing, and then the placebo wounds in the blue bar on the graph to the right, it goes up, and then because the wound gets bumped after it heals, and then it starts to heal again, and then the wound gets bumped, and then it opens up again. And this is the typical history of most of the EB wounds, as you know. And so it's not only just wanting to get closure of the wounds, not only closure, you want to be able to maintain the closure. And you see with the orange bar on the graph, you see that the wound area closes, and then you see over the 3 months, it stays closed. So that's what the BVEC's doing. It's not just making the wounds heal faster. As a matter of fact, sometimes wounds are stubborn and they don't heal very fast. And the BVEC it doesn't necessarily make the wounds heal any faster than they naturally would. But once they do heal, they will stay healed. And so that's the goal here. And so if you're thinking that the BVEC is going to make the wounds heal faster, it can, but it's not going. The real effect is going to be keeping the wounds healed once you finally can get the wounds closed. So that's why you want to do the good supportive care and do everything you can to get the wounds healed, because once they heal, then the BVEC will help them to stay healed. Can I have the next slide, please? And then on the basis of the good results on the phase 1/2 clinical trials, we went on to the phase 3 trials. And you see on the diagram on the right in number B, letter B, you see this is exactly how the BVEC works, or the Vyjuvek works. And that is, it's a virus. It's an HSV1 virus, so it's the herpes virus. And one of the things about the herpes virus is that it can evade the immune system. We all know that, when you get a cold sore, which is the what the herpes virus can give, then it'll go away, but then it could come back maybe a few months or a few years later. And that's because the herpes virus has figured out ways to hide from our immune system and not be removed. And so if you have a disease that has the herpes virus, then that's not a good thing, of course. But what we did here is we made the herpes virus so it cannot replicate, so it cannot produce disease. And then we put the collagen 7 genes in it. And then so all the virus can do is it just goes on the wound, it binds to the skin cells, and then it just dumps the gene, like you can see in the diagram here, it just dumps the gene right into the cell. And then the cell starts making collagen 7. And then the herpes virus doesn't do anything more. It just sits there because it can't replicate. So it doesn't produce disease, but it does a really good job of binding to the skin cells and making the collagen 7. So that's kind of how it works. It's pretty simple, really. Can we have the next slide, please? And then this is how the trial was set up. We have, um, paired wounds, BVAC on one wound and placebo on another. And it was double-blinded, placebo-controlled, randomized. So everything was set up to get the best, most objective results. And then also we treated some wounds open label with some of the leftover Vyjuvek that we had to provide more benefits and get some more data. And the primary endpoint was a very high bar. It was 100% wound healing after 6 months, which is it's a very high bar. But can we have the next slide, please? But despite that high bar, we were able to get a very significant difference between the placebo and the wounds treated with the Vyjuvek. You can see 67 versus 22%. And so this was really encouraging to us. Could I have the next slide, please? And but what I really was excited about more than anything else was the safety. Because up until now, with the in vivo gene therapy, when you're putting a virus on the skin or anywhere in the body's going to get an immune reaction. We all know this a lot because of the COVID virus that we've all gone through this last few years. And we know that once the virus gets in, starts to multiply in the body, there's a very significant immune reaction. And that's what causes most of the illness with these viral infections like COVID is all of the immune reactions. Our bodies trying really hard to fight the virus. With herpes virus, though, you don't see all of this inflammation, and that's because the body doesn't, mount a significant immune response against the virus. So that means these patients were using the Vyjuvek every week for 26 weeks, and you didn't see any buildup of any inflammation, and you didn't see any reduction in the efficacy of the drug. And so this is a major advance in the field of in vivo gene therapy using this type of HSV virus. And I will predict that a lot of other people for different diseases and different genes will be using the HSV virus in the future. Could I have the next slide, please? And then I'd like to be able to have you listen to this one of our patients who's been on this drug for now close to 5 years. And as you can see, he's got a very significant reduction of his wound burden. And also we are seeing systemic improvement as far as he's gaining weight, getting taller, his nutritional status is getting better, and he also hasn't had to use any iron infusions for his anemia. And so I think if we can get the video to play, then you can actually hear him firsthand. He's a really good speaker.
Hi, I hope you all are doing well. My name is Aaron Owens, and I'm here today to talk about my experience as a gene therapy patient. A short backstory. I was born with a rare skin condition called recessive dystrophic epidermolysis bullosa. And basically what that means is my body does not create a protein called collagen 7, which holds the top layer of skin to my body. And any amount of friction applied to my skin can tear it right off. So I have to be extremely careful with everything that I do in daily life. My first experience in gene therapy dates back to 2019 when I decided to participate in a topical gene therapy trial for epidermolysis bullosa. Before I started the trial, about 70% of my back was an open wound that would not heal, and the majority of both my upper arms would also be a wound that would not heal. At that time, I was severely anemic, and I was losing so much blood, and I was in a lot of pain, and just doing everyday activities would be a great challenge for me, and simple things such as sleeping on my back would also be really difficult. After about 3 months of consistent reapplication to specific parts of my upper back and my arms started to heal up and stay healed. That was really surprising to me because I didn't actually think it was going to work. After about a year and a half of reapplying the gene therapy to my back and my upper arms, 70% of my back healed up, and the majority of my upper arms were completely healed. And this significantly improved the quality of my life because I wasn't in so much pain. I wasn't losing so much blood. I was able to do simple things like sleeping on my back finally. And this really helped me a lot. Fast forwarding to today, 99% of my back is completely healed. And all my arms are also healed. And other parts of my body that didn't receive application are also starting to heal because my body isn't using so much of its resources to heal those areas as well. I hope that in the near future, there will be more advancements in gene therapy for those with my condition and others who can benefit from it. That was a short summary of my experience in gene therapy, and I hope you all have a good rest of your day. Thank you for your time.
Yeah, he's such an amazing individual, and he did get some very good results with this therapy. Could I have the next slide, please? And this just shows that we had one patient on the trial that had dominant dystrophic EB who did well on this trial. And I've been treating other patients with dominant dystrophic EB with Vyjuvek and getting some positive results. So I think that the idea here is that it's not only for patients with severe disease, but also patients with less severe disease, more localized disease. It also works. So don't exclude, physicians out there, don't exclude the mild patients from using the gene therapy. It helps them too. Could I have the next slide, please? And then this is a really remarkable case. This is a patient who came from Italy, actually, to join the phase 3 clinical trial. And he came with this large wound that covered almost all his back that had been chronic for over 10 years. But by the end of the phase 3 trial, he had almost healed it entirely, except for two small spots you can see on the upper back. And then by December of 2021, he healed those spots, and he wanted to go back to Italy and spend Christmas with his family members out there. And so he went back, and then about a year and a half later, he called me and said, "Oh, I'd like to be able to go back on the Vyjuvek." And I thought, okay, well, he probably wants me to retreat his back. So I said, okay, come on back. But when I saw his back was great. As you see there, it was a little bit dry. The skin was dry and flaky, but the wounds were still closed. And actually, they're still closed today. He wanted me to treat his legs when he came back in 2023. So this kind of shows that, that the durability is pretty good with this drug if you can get the wounds closed. Have the next slide, please. So again, I'd like to just talk about some practical aspects of how to use the drug. We've used plastic wrap, but one of the issues with the plastic wrap is that the wound has a lot of drainage. Then you'll get buildup of drainage overnight under the plastic, and sometimes that could, build up gunk and stuff like that. And so there's other alternatives that you can use, like for example, plain petroleum gauze. You can just put that over the Vyjuvek overnight. You can use Mepitel. Mepitel has some holes in it, but I mean, you can use it. But another thing you can do too is you can just use Mepilex and then cover the surface of the Mepilex that goes onto the skin, cover it with a layer of petroleum jelly. What you don't want to do is you don't want to use a a lot of these dressings are absorbent, right? They're supposed to absorb the wound drainage, which is that's what they're designed to do, and they do a good job at that. But if you're putting them over the Vyjuvek, what happens is the wounds dressings soak up the Vyjuvek, and then it can't get on the skin. So you want to prevent that. And so by taking the Mepilex and putting a layer of petroleum jelly on the underside of the Mepilex, a nice even layer, then you're preventing the Mepilex from sucking up or absorbing the wound drainage. So this is the basic principles of how to do an occlusive dressings for Vyjuvek. You don't let the dressings soak up any of the Vyjuvek and prevent them from soaking it up using the petroleum jelly, either already in the petroleum jelly gauze or adding it yourself. So I hope this is useful for you. And then one last slide I want to show you, and that is I just want to reiterate that the supportive care is really important. If you're putting Vyjuvek on a sort of inflamed or infected wound that is dry with a lot of crust over the top, you're not going to get good results. And unfortunately, it doesn't really talk about that on the label, and the doctors maybe don't know that so well at this point. But I can tell you, if you just clean the wounds up, really good, do really good supportive care, keep the wounds moist without any crust or debris on them, and keep them from draining, treat infections if you need to, optimize nutrition, get the iron infusions if you're anemic, try to get the hemoglobin up to 10 and get your nutrition really optimized. And if you do that, and then just sort of plan ahead when you have like a wound you want to treat with Vyjuvek, treat it with good supportive care for a couple of weeks beforehand, then start using the Vyjuvek, and you'll get the best results doing it that way. So that's the end of my talk, and I'll stick around, and I'll be glad to answer any questions you guys might have at the end of this session. Thank you.
Thank you very much, Peter. Very interesting, and especially all the tips and advices that you can bring to us for using Vyjuvek. So thank you. Let's continue with our second speaker, which is Natividad. Natividad, can you hear us?
Yes.
Yeah, you're here. So the floor is yours, Nati.
Okay, thank you very much. Hello, everyone. My name is Nati, and I have been a nurse at DEBRA Spain since 2008, as Emily mentioned before. First, I want to thank DEBRA International for trusting me to give this presentation. Second, I must say that my English is not very good, so please forgive me if I make some mistakes. Today, I will talk about different wound care products for people with epidermolysis bullosa. And I want to mention that all the products I will discuss are available in Spain, but I am not sure about their availability in other countries. So maybe you can check with your healthcare professional. Next, please. Also, I want to clarify that I have not conflicts of interest with any commercial brand. Next. Okay, as you know, EB is a condition that can lead to various complications. Blister and wounds are the main symptoms, but joint contractures, mobility problems, feeding difficulties, and eye complications as well can also appear. So that is why it is essential to consider the overall situation of each person, not just their physical condition, but also their emotional and social well-being, because this affects which wound care products we choose. Also, there are different types of EV, as you know, and this as well influences which products we can safely use, depending on skin fragility and other factors. Next, I will explain the main types of dressing and wound care products using in EV. First, here we have the primary dressing, as you know, which are applied directly to the wound. It's important that the dressing extend a few centimeters beyond the wound edges. Then removal should be painless and automatic. What option we can find? For example, silicone dressing like Mepitel, Cuticel, Astinet Plus. Another primary dressing are hydrocolloid meshes such as Urgotool or Urgofit. And the third one is acetate meshes with antimicrobial properties like Cutimex sorba is the green one. And as they have been widely used for, which can sometimes stick slightly. So careful with this one. You probably know the most of these products because they have been widely used for several years. I will focus on Urgofit because it's the newer one you may not be familiar with. So next, thank you. Here, Urgofit is a next generation dressing that creates an optimal environment for healing. It's the first 100% technology lipid colloid dressing, and it adapts well and it's very comfortable for patients. Here in the picture, we see a wound of the boy with recessive dystrophic EB. In less than 15 days, the wound had healed. The experience, the family said, the Urgofit dressing is very adaptable and very flexible. We are very satisfied with his application. Removing it's completely painless, which makes its use with children much easier. So I think it's a good experience of this Spanish boy. Next, secondary dressing are placed over a primary dressing, as you know. They usually absorb exudate, but as well in EV, they can also protect areas prone to friction. They can have soft silicone edges or not. So we have to option. The secondary dressing should extend beyond the primary dressing, okay? Example included foams, Mepilex Lite, Mepilex Ramfer, Mepilex, Aquacel Foam, Curtimet Siltec. Betadine Evo is worth mentioning because it contains ibuprofen, which is realized slowly into the wound, okay, helping to control pain locally. So very useful for painful wounds. Next one. Okay, here we can see example of the previous dressing here with the soft silicone border, as I mentioned. They are especially useful in EB types with less fragile fragile skin, as they can be applied without extra bandages. So next, please. Slide. Yeah, for example, here we can see two photos. In EB, in simple EB, they protect the heels, for example, or the friction areas, or are very useful, this kind of products, to secure catheters, for example, as you can see here in the first photo. Okay, next, please. Thank you. Another type of secondary dressing are fibers and alginates. Both absorb exudate and have high absorption capacity. They should be used usually with a primary dressing to prevent sticking. An example of fibers, Aquacel, Cutimed, Gelin Fever, Exufiber, Betadine Fever, Urgoclean. Next, we'll see different types of alginates. Thank you. Alginate example here, Cutimed alginate, Meldisor plus. The main difference between fibers and alginates is the composition, okay? The absorption of capacity. For example, alginates absorb slightly more than fibers, and alginates also help with the control of bleeding, okay? Next, thank you. Another type of dressing are the super absorbent dressings that have a very, very, very high capacity to retain exudate. This kind of dressing work like a baby dipper, more or less, okay? In EV, they are used for carcinoma stem cells, for example. Here you can see the photo. with heavy exudate, where wounds are painful and dressing changes are spaced every 4 or 5 days to increase the comfort of the patient. And you can see here the photo. It's very important. Do not put this type of dressing. Okay. Next one, please. Okay, now we are going to talk about preventive dressing, which are those that stimulate the healing process because they contain different molecules that promote it. I cannot go into much detail due to time, but it's worth mentioning that polymer contains an agent that helps with wound cleaning. The second one, you can see here in the first photo. The second one is cutimetepiona. It's a collagen dressing that is placed directly on the wound and is reabsorbed by the wound. You can see the second picture. And then the third one, how the dressing was absorbed by the wound, okay? And then we have the Urgostar used in chronic and non-infected wounds and helps reduce metalloproteases that appear in chronic wounds and hide their healing. Okay, they should not be used on infected or tumoral wounds. Then antimicrobial dressing are used for infected or heavily colonized wounds. The first one, silver dressing, are most common, available in forms, different concepts, different silver. And important, use them for between 2 or 4 weeks, no more, and caution with in children, okay? Then the copper dressing can be used long term, but experience in EB is limited, or as we don't have too much experience with this kind of dressing here in Spain. And then honey dressing help with cleaning and debridement, but they can cause itching, so maybe it's not an option for some types of EB. Then they come into different forms such as gels, meshes, etc. And finally, charcoal dressings, widely used to control the strong odor of some wounds, as you know, and important, cannot be cut and usually require a primary dressing to prevent them from sticking to the wounds, and a secondary one as well to absorb the exudate. Next, okay. In these images, we can see the use of a silver dressing on an elbow wound in a patient with recessive dystrophic EB, and the results were very good, reducing the amount of exudate and the infection in a short period of time. Next one, please. Okay, now we are going to discuss different types of ointments and creams that can be applied both on wounds and on fragile or dry skin. As you know, an ointment is a semi-solid topical preparation with a fatty base, like oil or petroleum jelly, that is occlusive and retains the moisture, as Peter mentioned before. Sorry. And then, as you know, it's occlusive and retains the moisture, and it is thicker and greasier than a cream, okay? And a cream is a semi-solid preparation applied to the skin or mucous membranes that combines oil and aqueous components. So this is the different, the aqueous components. Both are used to moisturize, protect, treat, or deliver active ingredients to the affected area where are applied. We can see here Filsubed. Filsubed is the first product developed specifically for epidermolysis bullosa. It is used on wounds to reduce healing time and is suitable from 6 months of age. It is indicated, as you know, for junctional EB and dystrophic EB. Although in Spain, we know that some people with simplex EB have also used it with good results. So this is another option maybe. Then Flaminal is used for exudative wounds, helps absorb exudate, and hydrogels. Although hydrogels are not considered creams or ointments, but are here because the presentation is similar, can be used to hydrate very dry wounds. The last one here, notably, Prontosan gel is not a hydrogel, but but its texture is very similar, and it is frequently used in EV, less here in Spain, to decontaminate wounds, can be used for prolonged periods of time, and does not create resistance as topical antibiotics do it. And it can be used from pediatric ages. Next. Okay, drink more creams. An ointment, drink cicatrizante and Cicaptip contain hyaluronic acid, which promotes healing. They should not be used on infection wounds. Then Reoscare, that is an antioxidant product that can be used at any time of wound, promoting healing. Then we have Curefini. Curefini is a protective and regenerative ointment made from natural products, and it is widely used in EV in Latin American countries. And the last one, the enzymatic debriders, help remove necrotic tissues and fibrin from wounds. They cannot be used with silver and are inactive by antiseptics or antibiotics. Yeah, the next one. Okay, here we have keratolytics. The first place are urea-based cream, used in areas with hyperkeratosis. For example, heels in simplex EB. They should not be used on areas where there is an open wound, okay, because maybe it's painful. Then we have sorry, this is a little difficult for me. Hyperoxygenated fatty acid, hyperoxonisate fatty acid are products used to prevent the appearance of wounds and to strengthen the skin. They can be applied to fragile areas where there are no wounds. For example, friction areas, wound edges, and peri-wound skin. The next one, please. Okay. Here we have the barrier products that create a transparent and protective film or layer that shields the peri-wound skin from moisture, exudate, etc. They are breathable and repel moisture. They are widely used around gastrostomies, for example, to protect against secretions, or in the deeper area as well, are very useful. They come in different composition, such as polymers or the last one, zinc oxide. Next, thank you. Other products are not very common, but maybe are useful, is the 4EB, include cleansing wipes, recommended for hygienic without the need for water and soap. They are useful in severe cases where bathing is not possible for different reasons. And they contain dimeticone, which protects the area where they are used. They do not replace barrier products. So first we clean with the whipper, and then apply the barrier product. We also have adhesive removers in the second line, which are useful to prevent skin injuries related to medical adhesives used in emergencies cases. For example, with the ACG, the electrocardiogram, adhesive patches. They should not be used, or these products, they not should be used on wounds or mucous membranes, and are not suitable for removing dressing stuck to the wound grass. Okay, they are well tolerated on fragile skin, but careful in the wounds directly. This one, please. Okay, regarding fixation products, on one hand, we have bandages, which should be made of very soft, breathable, flexible fabric to allow movement, especially over joint areas like elbows, for example. And on the other hand, we have tubular nets, which are very useful in the daily life of a person with EB. They help secure dressing and bandages, can be good to the size, and are available in different sizes for any part of the body. Okay. There are different brands, as you can see here in the picture. And then we have, yes, that's fine. Okay, this one. Thanks. And here we have the garments are also very useful in EV as they help keep dressing in place, especially in areas where bandages is difficult or tubular nets cannot reach. For example, in the deeper area, back or abdomen, they are breathable, flexible, made of soft fabric, and seamless. And here we have different brands like garment of Molige, Mubuker, Skinnies, and in the central picture is a Spanish boy that is using the gloves and the t-shirt. Okay. The next one, please. Thank you. The silicone tapes, probably all of you know, are useful for securing dressing and medical devices on fragile skin. There are tapes such as Mepitar or IPAFIX, as well as products specifically for securing intravenous lines like Leucomed, was they are in the middle of the slide. And these silicone tapes are adhesive, the regular adhesive tapes, you know. Okay, so. Okay, the products for the oral mucosas are used both to aid healing and control pain, as well as to prevent the appearance of lesion. They include a formulation based on hyaluronic acid combined with anesthetic, is the first one, Alocrer. The second one, vitamin A, is Beaoris, is used to prevent. And there are also pediatrics formulation available, is the third option after baby. After babies. Okay. Next one. Okay, thank you. And finally, it is worth mentioning that there are products that help in the daily life of people who have difficult performing basic activities of daily life, such as eating, for example. And here you can see some images. This is just a brief example. This topic, I think, will fill an entire webinar, which colleagues from occupational therapy and social work. So I don't know if you can click on the eight bones picture. No, because it's a video, but maybe it's not working. So don't worry, it's fine. It's the Spanish boy from Sevilla, and is using the eight bones. Is the same picture on the left. So next one. Okay, so this is my presentation. Thank you very much for your attention, and I hope this has been useful. Thank you.
Thank you, Natividad. Thank you, Peter, for these two amazing presentations. I can see in the chat that we have a lot of questions for you guys. So let me pick up some. So, first question for you, Peter, if you can hear me. From Michael, any information so far available about Visuvec eye drops, except the single case publication?
Yes, that's a really exciting development, and there is a clinical trial that Crystal Biotech, the sponsor for Vyjuvek, will be starting very soon. Right now, we're doing a natural history study of the eyes in recessive dystrophic EB, and once that is completed, then the clinical trial will begin. In fact, I think it's starting to begin now in some centers. So I think hopefully soon we'll be able to show the efficacy of the Vyjuvek in the eyes to kind of reduce the corneal erosions and pain in the eyes that I know many of you have. So this is I hope that this can once this is completed that maybe you can bring it to Europe as well, the ophthalmological Vyjuvek.
Thank you. Question also on Vyjuvek. Is this treatment only for children?
No, it's for
No.
adults as well. For if it's actually was just approved starting at birth, and it could be used all the way through into adults.
Another question, more technical one. Were the result of PVEC satisfactory also on wounds happening on parts of the body affected from birth with aplasia cutis congenita?
Yes, this is something I would highly recommend is to start treating with the Vyjuvek early. When you have aplasia cutis, if you let that heal without treating it, it'll get scarred, and then the scarring can last for a lifetime and always be a problem area. So I've used it really early on aplasia cutis and had good results. So I would highly recommend that you have to, of course, get the genetic diagnosis, and that could take a week or two. But as soon as you get the genetic diagnosis and can get the approval for the Vyjuvek, I would say start using it right away on those areas.
And from your clinical experience, how do you usually advise families regarding the timing of Vyjuvek treatment in relation to routine vaccinations? Interesting.
I would say you should not really worry about that. You can do the vaccinations; they're very important, and the Vyjuvek and the vaccinations together, there should be no interaction.
So we have again question on eggs. Is it already possible to use Vyjuvek in eyes, as we said, but also mouth and esophagus areas as well?
We're working on that. The formulation is maybe a little bit different. One of the things we're looking at is putting the Vyjuvek into dental trays to be able to then use on the gingiva to be able to make the gingiva stronger so that the patients can do good oral hygiene without bleeding. But past that, to get it to the esophagus and other parts of the oral cavity, there's a need to reformulate it. But I think in the future, it's definitely something that is being looked at right now, is getting the Vyjuvek into the oral cavity. And also in the anogenital area, too.
Promising. Another question, is there any gene therapy development for EB simplex, or can we use directly Vyjuvek?
No, unfortunately not. This is it's a genetic therapy, so it only works on the gene that is affected by COL7A1, the dystrophic gene. So unfortunately, we still have to we're working on developing the therapies for simplex and for junctional, but they're not ready for clinical use yet, unfortunately.
Okay. A question for Natividad. Can you explain how the TLC matrix, so I mean Urgodul, I think, works with fibroblasts? How does it stimulate fibroblast proliferation?
Thank you. Well, it's a interesting question because I don't know exactly in the cases we have tested here in Spain. I think we have tested in 8 or 10 patients more or less. The healing has been good and fast, so I imagine it does provide effective fibroblast stimulation. So I think so, yeah.
Yeah, because also it keeps the wound in a moist environment and it helps to the proliferation of fibroblast. Okay, thank you.
Yes, I think so. We use with a secondary dressing, so maybe it's promote the environment as well. So.
And another question, where do you apply on the body ErgoFit, which is another a new dressing, as if we understood well? Where in the body do you apply it because it's very flexible?
Yes, we have using elbows as well in the back in different places for the body, but it's very flexible. You can cut with your hands. You don't need a scissors, so it's extremely useful, I think. So yeah, you can apply and it stay in the wound, so it's easy to work to take the bandages or what you need. So it's a very good a new one product. Yeah.
Thank you, Nati. Another question for you. Does anyone know an oral lubricating spray to help to avoid mouth wounds or mouth scarring? Do you have some advice for the mouth? Cream or ointment or spray or?
For the mouth, we have some example here. Depend what you are looking for. If you need to prevent, for example, we use a Beaoris, this spray with vitamin E. Yeah. And then if you need to relieve the pain, we have Aloclair because it contains a little of anesthetic. So this is a good option as well. Promote the healing because it contains hyaluronic acid as well.
And a question for both of you, and thank you for the one who asked it. Regarding the wound dressing over Vyjuvek, could there be an hydrogel between wound dressing and skin surface, or should it be oil-based? So maybe Peter can answer this, and then you can give some example if you want, Nati.
Yeah, I mean the cream would have water in it that then could solubilize the Vyjuvek. And so I would recommend to only use an ointment, such as petroleum jelly or some other type of oil, rather than a cream. And I think Nati did a really great job talking about all the different types of absorbent dressings that could be used. But you don't want to use the absorbent dressings over the Vyjuvek because it'll just absorb the Vyjuvek. So a nice layer, nice thin layer of the petroleum jelly or other type of oil would be good. I like to use like a tongue depressor, or you can use like a butter knife at home and then just sort of spread it across the surface of the dressing like a nice thin layer, like you're putting peanut butter on bread. And then you could put it over the top of the Vyjuvek in that way.
Okay, nice. Thank you very much. Nati, do you want to add something?
No, it's very good
okay.
explication.
I can see a lot of questions about where Vyjuvek is or will be available. For this, you can also send us an email because, of course, we won't detail all the countries. If you want to say a few words, maybe Peter, but of course, in the US and for what I know in Europe, more and more countries have now access in hospital. But of course, we can also link you directly to Crystal Biotech if you want to know more about your own country.
Yeah, I mean, I spent a lot of time and effort trying to help and develop this Vyjuvek, and I want to see as many patients to benefit it from it as possible. And so, unfortunately, though, it's up to Crystal Biotech to be able to get the approval in like the different countries, and it's up to the countries to be able to, have the agreement with Crystal. So sometimes this takes time. But I would say I'm always trying to get Crystal to, be as aggressive as possible. And I believe they are, but it just takes time to be able to get negotiations with all these individual countries. But I definitely would forward these comments to Crystal so that they're aware of this.
Thank you. Thank you very much. This is time to close this nice and very useful webinar. Again, I would like to thank you, both of you, Peter and Natividad. This webinar was recorded, so it will be available on our website as a replay. So see you soon. Have a good day, evening, afternoon, night, depending on where you are, and see you soon for other webinars from DEBRA International.